Hi, I'm Lauren Stewart. I'm an emergency medicine physician at Indiana University, and I'm going to be talking about the role of statin therapy in venous thromboembolism, particularly its impact on VTE recurrence. I'd like to thank my mentor and additional co-authors for their help and guidance with this project, and I have no conflicts of interest. Venous thromboembolism, defined as deep vein thrombosis and pulmonary embolism, is the third most common cardiovascular disease nationwide, with approximately 900,000 diagnoses annually. VTE recurrence not only increases the risk of mortality, but also creates significant patient morbidity, prolonging the duration of anticoagulation therapy, worsening quality of life measures, and leading to an increased risk of developing chronic thromboembolic pulmonary hypertension. The need to better understand who is at increased risk of recurrence and how to reduce these risk factors has become increasingly apparent. Statins may represent a novel pharmacological approach to prevent VTE recurrence. In addition to decreasing cholesterol synthesis, statins likely demonstrate secondary antithrombotic effects through decreased platelet activation and aggregation and increased endogenous TPA activity. Additionally, statins may display anti-inflammatory properties, evidenced by decreased circulating C-reactive protein. In a secondary analysis of the Jupiter trial that investigated the role of rosuvastatin versus placebo in patients without previous cardiovascular disease or diabetes, statin allocation was associated with a significant reduction in VTE incidence compared to controls. However, the role of statin therapy in the secondary prevention of VTE recurrence is less defined, with prior studies demonstrating mixed results. The objective of this study was to determine the prevalence of statin use across a large statewide population of patients with VTE and to examine the magnitude of effect of statins on VTE recurrence in this population-based sample after matching for comorbidities between patients prescribed or not prescribed statins. This was a retrospective analysis of a continuous population sample conducted in collaboration with the Regenstrief Data Core. We utilized de-identified patient information from the Indiana Network for Patient Care Database, a large statewide health information exchange. Any patient with a diagnosis of either DVT or PE based on appropriate ICD codes over the specified study period of 2004 to 2017 was included. In patients with an ICD-based diagnosis of DVT or PE, we also collected demographic data, as well as the presence or absence of several predefined comorbidities. We collected associated generic product identifier codes to determine whether patients had been prescribed the statin medication and recorded the presence or absence of recurrent VTE, defined as any subsequent ICD-based diagnosis of DVT or PE occurring after the index event. We measured the overall prevalence of statin use in patients with VTE. We then divided patients into two groups based on whether or not they had a documented prescription for a statin medication and compared proportions of baseline comorbidities as well as the incidence of VTE recurrence between groups. To account for differences in baseline characteristics between patients with and without statin use, we performed a propensity matching analysis to balance covariates. We then obtained standardized differences in means between each variable to test for balance and created a final logistic model with statin use as the predictor variable and VTE recurrence as the dependent variable. The study sample included a total of 192,908 patients with a diagnosis of VTE. The median follow-up period was 5.8 years per patient, and this represented 1.1 million total patient years. Overall, 13.5% of patients were found to have a documented statin prescription. VTE recurrence occurred in 16% of all patients over the study period, with a median time to recurrence of 2.7 years. This table displays the pertinent demographic and comorbidity data for patients stratified into statin use versus no statin use. In this unadjusted model, statin users were significantly older, more often male, and had a higher incidence of smoking and all comorbidities except for anxiety. When separated initially into these two groups with no propensity matching, there was no difference in incidence of VTE recurrence, with both groups having a 16% incidence of recurrence. This table again shows demographic and comorbidity data, this time after we performed a propensity matching analysis to balance covariates. Propensity matching yielded the following two groups, statin use and no statin use, both groups including approximately 26,000 patients. Statin and no statin groups were much more closely balanced after this exercise, although small differences in proportions still existed. After propensity matching, the incidence of VTE recurrence was significantly higher in those not on a statin, occurring in 20% versus 16%. Logistic regression analysis was performed in this matched population with VTE recurrence as the dependent variable and statin use as the independent predictor variable. This yielded an odds ratio of 0.75 for VTE recurrence for those on statin therapy versus those not on statin therapy, suggesting a protective effect. In this population-based analysis of over 192,000 patients with VTE, we found statin use to be associated with a reduced risk of VTE recurrence. We believe this study to be novel in its size and scope. To our knowledge, this is the largest database examining the role of statin therapy in VTE recurrence to date. Although the mechanism by which statin therapy may afford protection against VTE recurrence is not clearly understood, it is thought that this is likely secondary to a combination of anti-inflammatory and antithrombotic properties, possibly as downstream effects of decreased cholesterol synthesis and increased hepatic uptake. Our findings support several prior studies. The recent START trial, or statins reduce thrombophilia, examined whether statin therapy affected specific coagulation parameters in patients with a history of VTE. After withdrawal of anticoagulation therapy, investigators of that study randomized patients into one of two groups, rosuvastatin 20 milligrams per day for 4 weeks, or no intervention. They compared plasma samples at baseline and at 4 weeks and found statin use to be associated with reduced thrombin generation potential. Our findings add to prior evidence supporting a proposed role for statin therapy in the management of VTE, perhaps as an adjuvant therapy initiated at the time of VTE diagnosis, or prophylactically at the time of anticoagulation withdrawal in an attempt to reduce risk of recurrence, especially in patients with moderate or high bleeding risk. Whether their use would be of greatest benefit across all patients with VTE or specific populations, such as older patients, those with underlying cardiovascular risk factors, or those unable to tolerate anticoagulation, needs further investigation. The study had several notable limitations. First, given the methodologic framework of the study, diagnosis of VTE was dependent upon ICD coding. Further, given the potential limitations in the scope of access of our database to outpatient prescription data, it's possible that a proportion of patients in the negative statin group actually received a statin prescription that was not captured in this analysis. This could also occur if patients received care out of state or out of network, leading to missing data. The lack of objective data, including fasting lipid panels, is an additional limitation. In conclusion, in this large study with long-term follow-up, we found patients with VTE and a documented prescription for a statin medication to have a significantly decreased risk of VTE recurrence. We believe these data support the need for a prospective, randomized controlled trial evaluating the role of statin therapy in the secondary prevention of VTE. Thanks for your time, and please feel free to email me with any questions or comments.